Yes, sir.
Yes, sir.
Okay, thank you, and welcome to this session, clinical contact session of week 5 of this year's clinical management of HIV course. My name is Dr. Anwar Sayed, and I work with ITech as a country director. It's good to be a part of this gathering here today. And I could not join before, but I'm happy to be here for this session. I hope the sessions are going on and you are keeping up with the homework assignments and the quizzes which are required for the course. I know sometimes it becomes really difficult to take time out of the routine work and do the assignments, but if you keep doing them within time, I'm sure it won't take much time. So today's topic is, as this is week 5, and like every time, you might have attended those two by the university faculty, and I'm sure you might have those two sessions, which were clearly a demarcation between the how the HIV is treated in Western world versus in those countries where there are no much of the facilities available, and whatever is available, the way they manage HIV or treat HIV in those countries. So that was a good, perfect example for all of us actually to view as against what we do in our national program. As I understand, you are the are working at ART Science or working for some of you are not, but I have a perspective of in all there will be one is as production country, and another one is regarding resistance to antiretrovirals, and also it will have discussion on toxicities and all. So for this week, and as you are aware that these sessions, which are conducted once in a week through ITech, these are clinical contact sessions. So it is assumed that participants have already gone through this done by the university faculty. So we will touch base of the relevant areas which are there in our national program
Anwar,
of
your
NACO
voice
or
isn't
NACP.
clear. Dr. Anwar, your voice is not clear.
Can you hear me? Maybe because of the internet connection, I'm doing this through Wi-Fi. Is it better or is it same?
Yeah, it is better now. Yeah. Just speak more.
I apologize for this because this will happen in between. As my Wi-Fi connection is not stable, so it may come and go. And unfortunately, I don't have access to any other internet connection during this time. Okay. Yeah. Thank you. So let's start. The session done by the UW faculty, as I was mentioning before, there was a clear demarcation between two kinds of approaches. One is individualized approach, which is done by case-to-case basis, where you have liberty to select a regimen of so many, keeping the basic principles in mind that it has to be two-drug treatment or three-drug therapy, and which will be an effective or potent combination to treat HIV positive, and where you have liberty to select the medicines based on like pill size and what the person like, dislike, and also based on the potential side effects with which the person might face in future, and the money cost. So all those factors come into play when we select individualized approach, and which is available in the Western world, where people have liberty to use and other kinds of like supports to treat themselves. But is like those which are low income or middle income countries, we usually go with programmatic approach, where you have treatment based on line of treatment. So rational sequencing of drug matters a lot in such scenarios where you have a preferred first line, which if fails, you have a preferred second line and third line. So in NACO's program, we use programmatic approach for treatment. So to get into the treatment part, it's really important to run through the life cycle again, which I'm sure was done once first in the first session itself. But to again revise that, it's really helpful to understand the mechanism of action of the drugs which we use in the national program. And in HIV scenario, it is helpful if we are thorough with the cycle of HIV, because the regimens are changing, new drugs are getting in, and there are multiple combinations people use. So, but fortunately, the targets for HIV, they are which where the antiretroviral drugs they act, they are very few, and they are because they define actually class of ARB medications. So in this diagram, if you can see my cursor here, so this is HIV virus, and when we talk HIV virus, as you know that this is an RNA virus, and along with RNA virus, there are three enzymes with which HIV comes into the human body. And when it comes into the blood, and when it actually get itself attached to the CD4 cell, and this blue thing here is a cartoon of the CD4 cell, and this one is a nucleus. And in the nucleus, you will have the human DNA available. So when HIV comes in here, it enters along with its single-stranded RNA and three enzymes. And name of three enzymes are reverse transcriptase, integrase, and protease enzyme. First thing what HIV does is conversion of this reverse transcriptase, the single-stranded RNA to double-stranded DNA by the help of reverse transcriptase enzyme. And this being the most crucial step in the HIV multiplication becomes the first target for antiretroviral drug. So the since all these almost decades now, almost two decades now, so enzymes blocking of this enzyme. So most of the times, this reverse transcriptase inhibitors, whether it be nucleoside or non-side reverse transcriptase inhibitor, or nucleotide reverse transcriptase inhibitor like tenofovir, all these drugs have action of this enzyme, which actually brings about version of single-stranded RNA to double-stranded DNA. And after that, what happens is this double-stranded DNA is called as proviral DNA, which contains virus genetic material. It is actually brought into the nucleus and integrated into the human DNA by the second enzyme, which is called as integrase. So if you block the action of integrase, this second crucial step does not happen. And and at this stage, the human DNA will have a part viral DNA as well. So that genetic material has already incorporated into the human DNA, after which it will be almost impossible. And then when maturation happens, messenger RNA comes out, and from the translation of this messenger RNA, viral proteins are formed, and maturation of all this genetic material happens, and through but this virus goes proviral forms the longer viral proteins to cut it short to the suitable size to make a new viral copy. So this enzyme that is, and if you block the action of protease, this is crucial. There are some other steps also, like this fusion, which we skipped. So when the virus attaches to the CD4 cell, this step is fusion, where the HIV receptor, that is CD4 receptor, co-receptor, also be blocked by fusion inhibitors. But these fusion inhibitors, that is why we don't discuss them much. So in the clinical, the enzymes which are relevant to the clinical practice, transcriptase enzyme, integrase enzyme, and proteins, and they block the action of these enzymes are called as transcriptase inhibitors, integrase inhibitors, and inhibitors. So as I mentioned before, all these years we have been relying on reverse transcriptase inhibitors for as a first line ART, but very soon soon you will be seeing integrase inhibitors entering offline ART itself. Protease inhibitors are available in the program, but
Sorry for the inconvenience. I think sir got disconnected. Hope he connects soon.
I hope I'm audible now.
Yes, sir.
Yeah, so we were talking about these three enzymes whose activity can be blocked by the ART drugs, reverse transcriptase, integrates, and protease. So these are the drugs which are there throughout, and there are drugs which are available right now in the program which have been marked. Those which have been, if you can see. So these are the drugs which are available in the nucleoside reverse transcriptase inhibitors, of which lamivudine abacavir is still available in the program. The other drugs
Sir,
are not
sorry to
available.
interrupt. Yes, sir,
Then
sorry.
nucleotide reverse transcriptase inhibitor, we have tenofovir. There is one alternate of this particular drug that is which was spoken by the UW faculty into their sessions. So this is TDF, is tenofovir disoproyl fumarate. But the other form of this is TAF, that is tenofovir alafenamide. So the newer version is being currently used a lot in the clinical practice by private physicians these days. There are differences between the two. We can discuss those later. But the major difference between TAF is in terms of their toxicity profile. TAF does not have this renal toxicity and also bone marrow, bone mineral density, which is lowering of bone mineral density side effect of which does not happen with TAF. So it has many advantages, and it is being used increasingly in the private setups. So, but the fusion inhibitors, there is just one drug available in this category right now, which is actually an injectable drug approved by FDA. But as I said, it is not used in clinical practice. Among nucleoside reverse transcriptase inhibitors, efavirenz is the one which is still being used in our program as well. Been we have reduced its use, still being used, but slowly use is going down. The ribavirin is another drug which is reverse transcriptase inhibitor again. Now, amongst the integrase inhibitor, raltegravir, we were using an alternate second, third line drug program, but raltegravir is one new drug which has entered into the program, which is being used as again alternate second line or third line. But very soon it will make its entry in the first line as well. The chemokine co-receptor inhibitor, as I was mentioned in the when the virus enters into the CD4 cell, it requires the CD4 receptor and receptors. There are two co-receptors, CCR and CXCR4. So the drug like maraviroc, it actually blocks action of one of the co-receptors, CCR5. So we need to do actually the co-receptor thing for to actually find suitable people for treatment with this. It is not much clinical practice, but at some stage it may be used. So protease inhibitors, there is a long list of drugs. You'll see maximum drug in this list. But if you see those which are given to us, these are utanavir, ritonavir, atazanavir, and darunavir. These are drugs which are available within us. So there are many goals of RT clinical goals that clinically you want your patients to be best and it should be an event-free survival means. Virologically, you will want your patient's viral load to be suppressed to a level where it may be so it undetectable viral load test. So that is greatest suppression of the viral load. Immunologically, you want patient's CD4 to be highest possible, both qualitatively and quantitatively. And third goals are, which means that for a program, when you introduce a first line of treatment, so in a major context, you see how these drugs can be sequenced if the first line of treatment fails. So it has to be some rationalization of the sequencing of drugs in a manner which achieves all these virological and immunological and clinical goals. And also there is a public health benefit of treating the patients with a combination of effective combination of that means that you might have heard the concept of U is equal to U, that is undetectable is equal to transmissible. So if you are treating patients with ART and viral load goes down below the detectable level, at that level person not be able to transmit HIV to the other person through sexual route of transmission. So that is U is equal to U. If people are on effective therapy, those who are known HIV positives, it is assumed that they will not spread HIV through the most common mode of transmission, which is sexual route. Eradication of HIV has not been possible yet because you know that HIV actually goes the reservoir sites from where it is difficult to eradicate the virus. But you might have heard the isolated cases of cure from like some news items seen Berlin patient and London patient recently. These are a couple of cases where eradication has been possible, but that was not part of a standard treatment protocol as such. Both the patients were having a virus which was were treated actually with for malignancy and where bone marrow transplant was done. Fortunately, they were having a kind of virus where they got cured because of the new marrow they received. So, but that cannot be a treatment strategy for everyone as such. That was accidental cure, you can say. But the functional, of course, is possible. We say that person is who is on treatment will some load and where the viral load may be detected and where the person will not be able to transmit HIV. But of course, the HIV can be there in the reservoir site. And some sites work as reservoirs where HIV goes and hides itself, which are the immune stem cells like T lymphocytes, macrophages, and brain and gut and all, where the may survive for so in resting stages. So in terms of ART initiation cutoff, those who have worked in the program for a long time, they know better that earlier we used to initiate ART only for those patients who have CD4 less than 100 cells. And then we did not have access to viral at all. But then that with ART initiation with CD4 less than 350 and then less than 500, and recently since April end to be specific, the guideline of TTOL was launched where everyone who is HIV became actually eligible for ART. And since then, in the NACM also, we are starting ART to each and every person who is diagnosed HIV positive through ICTC. So, but now, one data which is with us is viral loading. So we are not doing viral load test at baseline. Why we are not doing that? We'll see in the later sections when we deal with the viral load guidelines. But let's see what is needed before we initiate a person on ART. So when we initiate ART and why ART is needed, first of all, for in HIV positives. Of course, we want the longer survival and we want lesser opportunistic infections to happen in HIV positives. So once the person goes on ART, reduces risk of infection, obviously, because the immunity will be rebuilt or reinvigorated. Then incidence of TB will be low and mortality will be less, and also the quality of life of the person will improve. There are lot many benefits of ART, as I already have mentioned quite a few. But in addition to that, public health benefit, we should keep in mind that once you have something to offer, a treatment to offer in any disease, people will also come forward for testing of for that particular disease. So there are some considerations need to be made before ART is initiated in the national program. First of all, the HIV testing need to be confirmed at the ICTC. And once the ICTC gives a HIV positive report, the person is registered at AR center. That is called as pre-ART registration. Until now, until very recently, we were following up with this concept of pre-ART care because we were not initiating ART to everyone. So there was a pool of patient in pre-ART care for long duration of time. But since the time of ART for all or treat all, we are seeing reduction is in this pool of the patients which were there in the pre-ART care. So now with decreasing number of pre-ART patients, we will have two types of patients. One, those who are in preparatory phase for ART initiation and those who are on ART. So this pre-ART concept will is slowly going down. Once we get the patients registered, we actually do the baseline clinical checkup of patient to see signs and symptoms of other opportunistic infections like common ones like TB or other OIs. And then we also do some lab workup to see what is the level of immune suppression and what is the how kidneys are doing, how liver is doing, how hemodynamically if the patient is not, by doing all these baseline investigations, which are some are mandatory, but again, it has been explicitly told many times that those investigations, if they're getting delayed, should not delay ART initiation for the otherwise fit clinically fit HIV positive. So I'll come back to that point. If there's any opportunistic infection, if that is identified, so the rule of thumb is to treat the OI first before ART is initiated. So when I say treat OI first, it doesn't mean you need to complete that OI treatment. It means that OIs should be treated sufficiently enough to say that they are under control and the immunity is being rebuilt, and then the person will be perfect time for the person to go on ART. So this time duration between the diagnosis and to the ART initiation in presence of OI depends on what OI you are treating the patients for. So if there are some OIs or opportunistic infections where you missed ART initiation, which is best for the patient, there are some OIs where you want delay ART initiation. So to mention a few, for example, in cryptococcal meningitis or TB meningitis, so these are a couple of conditions where you want to delay ART initiation a bit for 4 to 6 weeks, maybe 2 months time, because early initiation of ART in such opportunistic infection may prove to be fatal in some scenarios. On the other side, there are OIs, for example, again in TB, if the CD4 is very low, then it is recommended to start ART as soon as the patient has stalled TB treatment, so that we can reduce the overall mortality in those clients. So it all depends on the clinical presentation of the patient and presence of what OI you're dealing with, which actually decides when the ART is to be started. Then there is another important consideration which is to be made is regarding preparedness. So if at all we say that ART can be started for everyone, but also we need to consider that the patient should be absolutely ready for ART initiation. There can be some patients who may be in the denial phase, who don't want to accept that they are HIV positive, who don't want to go on treatment, they are not ready for ART. So in such patients, we should not be hurrying ART initiation, because if you are not sure if the person is not willing for ART, then the adherence will be an issue, and then whatever potent ART you are offering is not going to work because patient is not to take it. And if there are some other coexist problems like alcoholism or forgetfulness and person comfortable taking ART, though all those issues need to be addressed in preparedness phase. Again, counselors are really helpful when it comes to ART preparedness because of their experience with the patients or diverse patients they have seen over the period of time. So this phase is really critical in HIV, in PLHA's life, and also in our approach as a clinician when you see the patients at the ART center. So we need to spend more time with those patients who are yet to be initiated on ART and to prepare them well, to explain them what are the benefits of ART, to again talk about the potential toxicities for which they have to report. So with change of ART over a period of time, now we are using the ART drugs which are less toxic than before. So we need to explain benefits and get the people ready for ART initiation before we actually start them on ART. Then obtaining consent, we actually take a written consent also at the time of registration, which also includes the consent for ART initiation and follow-up and home visits and everything. You can go through the consent form. In the new version of the white card, the consent form has been already printed on the white card itself. Then timely ART initiation, as I mentioned before. So patients should be adequately prepared before ART initiation. And one more aspect of ART initiation is identifying a proper caregiver, which becomes still more important in pediatric cases, because again, children, if they are not able to take care of their own, you will have to have a good caregiver identified, and that person also need to be counseled about benefits and everything about ART and why adherence is important, and all those things need to be properly explained. And if the patient requires any kind of prophylaxis, that need to be started. And right now we are offering in national program two drugs as a primary prophylaxis. One is cotrimoxazole to prevent the one of the deadliest opportunistic infection if not treated well is pneumocystis carinii pneumonia, that is PCP, which can be prevented through a simple drug of Septran or cotrimoxazole or cotrimoxazole prophylactic therapy. The combination of sulfamethoxazole and trimethoprim, one double strength tablet, which is given to all PLHIVs if the CD4 is less than 350, if they fall in WHO clinical stage 3 or 4, or obviously pulmonary tuberculosis or any kind of tuberculosis. That's it. So once you start cotrimoxazole prophylaxis, the person is continued on CPT prophylaxis for at least 6 months of time, and it can be stopped when the CD4 is more than 3, at least on 2 occasions consecutively. So other kind of prophylaxis which we give, which can be given even which is usually given after ART initiation, which is IPT, that is isoniazid preventive therapy, which we'll discuss later. The other kind of prophylaxis in our national program is recommended. Of course, there is a something called as prophylaxis for some diseases, which can be discussed in the OI session. So these are the there are 3 tables which I'll just run through. Based on the OI you are dealing with, you either start ART early or you delay ART initiation. Like I mentioned, you need to actually remember at least OIs like this and TB meningitis where you delay ART initiation. Otherwise, as soon as the patient is stable on treatment, you can start ART in those patients. In the sessions done by the faculty, OIs in relation to ART not discussed much, because as they also mentioned, this is the problem of developing and low or middle countries, where we still see many of the cases of tuberculosis and other opportunistic infection, which is not the case in the Western world. So that is why it is really important for us as people who work in the to know about diagnosis, then clinical presentation and management, and immune reconstitution syndrome, which is related to all these opportunistic infections. So it becomes really important for us to know about these OIs and when to ART in those situations. One specific thing which I mentioned for in TB, Depends on the CD4 count. If CD4 count is less than 50, then you start TB treatment and ART simultaneously, which means you need to start TB treatment first. As soon as the patient is stable on TB treatment, you can go ahead and start ART in those patients. So as far as assessment is concerned, you need to thoroughly assess the patient from head to rule out any signs and symptoms of clinical stage 3 or 4 opportunistic infections. Also, it is very important to take the detailed history of ART, what drug was used in the past as treatment or prophylaxis or part of prevention of mother-child transmission program like PPTCT, like exposure to none and all that. And it is good to know about patients' other coexisting morbidities like diabetes or hypertension or hepatitis or co-infection HBV or CV co-infections. History of all these things which will help us to decide the appropriate regimen to begin with or to modify the treatment once we go along with the treatment in future. Then also it is important to physical needs of the patient because that support is really crucial, at least in the initial years of the treatment. And also if it is good to if the patient is having any CNS it's not good to know actually. We should know about all these things because based on this we may have to modify treatment sometimes. About the medication of people who of injecting users or history of unprotected sexual intercourse with any sex worker or any other partners, history of AIs and patients belonging to the risk groups or any other practice. All these things make part of medical history, which is important to know. And when it comes to general examination, so both the like routine general examination when we see like temperature, pulse, respiratory rate, or blood pressure, or lymph nodes, and all those things, vitals, and everything. So that becomes really important before at the time of registration and also at the time of ART initiation. Then, as I mentioned, head-to-head examination really helpful to identify or diagnose opportunistic infection. So, and depending on the system which is involved, we do clinical detailed systemic examination also in such patients. So, as mentioned by the faculty, these things were not discussed enough because, as I mentioned, that many of the opportunistic infections. But in our program, it becomes really again important for us to know and rule all these OIs. About the baseline investigation, sometimes I've seen that that itself becomes a barrier for ART initiation. If somewhere something in the list is not available, PLHIVs are kept for ART initiation. So that is not the guideline. So it is expected that all the essential investigations are to be done before ART is started to rule out the infections and opportunistic infections. But it is delaying ART initiation if as a clinician you think that clinically the patient is stable to start ART, the patient ART on, then you can start ART without investigation. But you need to get the investigations as soon as they are available to you. So as far as stuff essential investigation is concerned, complete hemogram is expected to be done. Then urine routine and microscopy, blood sugar to rule out again diabetes. Serum creatinine is one which all of us are concerned about because we are starting the patients on tenofovir. But again, as I said, if you are starting the patients on treatment, then you if at all, if suppose it is not possible at all on the same day, then you can still take a chance and start patients on tenofovir and ask the investigation as soon as these investigations are available to you. But again, doing all the investigation when they are available is essential. And C4 we do and lip profile if it is available, especially if we are starting on the PI based ART and also on rifavirin. Then HBS, AG, and serum or hepatitis testing important, especially in those people who are who inject drugs. Then other essential investigation, if they are required, the X-ray test and pregnancy test if it is available, and pap smear, especially in the women or MSM population. Additional tests which are symptom directed. If the person is having 4 symptom positive, then obviously you will do cBNAT of the available sample, which is again to rule out tuberculosis. Some ultrasound abdomen is required for those patients in whom we are suspecting those abdominal B or lymph node enlargements and all that. Then LFT, complete liver function test required, especially in those who are hepatitis B or C co-infected, and other investigations again as I said, symptom directed. Already spoke about preparedness counseling. We don't say these days that ART is not emergency, but we still say that ART should be started as soon as possible, even though it's not a for namesake it is an emergency intervention as such, but early initiation is highly encouraged, and as soon as possible patients should be started on ART for the person's benefit and also for the programmatic benefits. So this is why adherence is really crucial and important. This is example from a couple of studies which were done PI-based ART regimen, where you can see on the left side of the graph the percentage of the patients with undetectable viral load. So what it says is that if the have more than 80% viral suppression, you will have to have more than 95% of the viral load of ART adherence. That means those who were having more than 90% adherence to treatment, of those also just 81% of the patients were having viral suppression. So which means if you want to have a successful outcome of ART treatment, there has to have highest quality adherence to ART. So if the adherence levels are not good, so whatever potent drug you are using, so that drug will not be useful. So, I mentioned before, Test and Treat was launched in 2017, which actually opened the door of ART initiation for all categories and kinds of patients, those who are HIV positives. Regardless of CD4 count or WHO clinical staging or age or population type. But there are basic principles which need to be kept in mind before ART is initiated, that it is a combination therapy and at least 2 or 3 drug combination is used in the national disease. So this is the combination which is used right now, that is tenofovir, lamivudine, and efavirenz. It's a dose combination which has so many benefits, like reduce pill burden. It harmonizes the population. All types of population we can use this type of a drug with 1 or 2 exceptions, which we'll come to later. But otherwise, this is very safe combinations to be used, and majority of the population in our program of 1.3 million people on ART actually nation and lamivudine 300 milligram and 600 milligram, which is taken at the maybe 2 hours after the meal, or actually before the meal also it can be taken. So 1 hour before or 2 hours after the meal it has to be taken. So this is again to avoid the side effects of the efavirenz. We will talk about the toxicity in another session maybe, but just to mention that tenofovir, I mentioned before, also may have renal toxicity and also may have may reduce the bone mineral density, which may lead to lead a person for fractures. But the benefits again are rich, and there are many advantages using efavirenz as compared to nevirapine. That is why nevirapine was taken out, and efavirenz is our frontline drug which is used in the national program. So lamivudine we'll see in majority of the regimens, because it has many benefits. Once it is used in combination, again, even though this is the drug which can be having very low genetic profile for development of resistance, but presence of the mutations which actually are may develop in relation to lamivudine, that increases sensitivity of the other drugs with which it is being used, which means that using lamivudine and also in second line is beneficial for overall treatment outcomes when it is used the other drugs. So it also makes the virus unfit or less fit. So all these issues we'll be talking about in the next session, future session of the HIV resistance. So I was mentioning, so this is the preferred first line right now in the program. Very soon, when TLD will be available for the new patients, in place of TLE, TLD will become first line. But that will only happen when it is available into the national program and when the office memorandum from NACO is released to use TLD as the first line for treatment initiation. So that will come when it comes. But right now, this is the first line. If for some reason we are not happens in case HIV2 doesn't, the NNRTI actually does not act against HIV. That is why we will have to use lopinavir in place of reference. And also, if the person is exposed to NNRTI in past as a part of maybe prophylaxis or treatment, and most commonly those women which were given nevirapine in past as a PPTC regimen, in those patients we cannot use NNRTIs, and that is why we use lopinavir as a alternate first line. So tenofovir and lopinavir becomes alternate first line drug for those patients. So tenofovir can be used only if the is more than 10 years of age. Cannot use tenofovir in the national program right now. It is not that it is contraindicated below 10, but the preparation we have in the national program right now doesn't allow us to use below 10. If you see the FDA approval of tenofovir, it is approved for the patients 2 years of age. Those formulations are not available with us. That is why we are not using. And also the combination which we have tenofovir lamivudine or tenofovir lamivudine efavirenz combination, which has tenofovir 300 milligram in it. It can be used only if the body weight of the patient is more than 30 kg. And also, if for some reason, if we are not able to use tenofovir, maybe because of poor creatinine clearance, which is if it is less than 50, so where you cannot use full dose of tenofovir, in those cases you have to use abacavir. So abacavir is a drug which does not have any renal effect. So that is why it is safe to use in nephrotoxic patients. And the combination will be then abacavir, lamivudine, and efavirenz. But it is not used based on just serum creatinine levels. So you need to calculate creatinine clearance by using Cockcroft-Gault formulas, which these days there are so many applications, mobile applications which are available to calculate creatinine clearance based on weight of the patient and also age and also serum creatinine. So based on all these factors, it calculates creatinine clearance. And if the clear is less than 50, you won't be able to use tenofovir, and in some cases, abacavir becomes the drug of choice. So it will be abacavir, lamivudine, and efavirenz. So if patient is, as mentioned before, co-infected with HIV2, you will not use NNRTI. That's why it will be tenofovir, lamivudine, and lopinavir. And those women who were exposed to nevirapine in past, obviously, you will not be using NNRTIs in those patients. So those patients who are already on ZLN or ZLE based regimen were continued on the same regimen when the TTOL or with TLE was made uniform preferred first line for all patients. So till now, also those patients who are on ZLN or ZLE, they are continued on the same regimen. So now, but recently the new drug has been introduced, and we are now in the phase 1 of dolutegravir. As I mentioned before, this is an integrase inhibitor. So this drug is is a lot in discussion these days. You will be seeing in private again a lot being used, and also in the national program, it has made its entry as a. Now we are in phase 1 of its use. So I'll just come back to what is one after some time. But before that, just let's try to discuss why dolutegravir based regimens are being preferred these days. DTG is its short form. It is being used because it rapidly suppresses viral load. It has very few side effects. It is very drug. It has minimal drug interactions. It has very high genetic barrier. It can be used against all population of viruses, including HIV2, and also it harmonizes treatment across the different patient populations. When I said it reduces viral load quickly, that is rapid viral load suppression. So there are a lot many studies which can be quoted, but one study, that is single study, which says that is the 12 weeks viral load suppression. It is very as compared to the efavirenz based regimen, which brings down the viral suppression at 12 weeks. The DTG based regimen brings down the viral suppression at just 4 weeks. You can just compare the two graphs, and this is the line of treatment for the week of on ART, and this is portion of patient with viral suppression, and quickly it reduces the viral load and brings down to undetectable levels or suppressed levels, as compared to the efavirenz based, which takes at least 14 to 16 weeks for suppression to happen. What it means is it has individual benefit for the patient, and also in terms of transmission, it has huge benefits that if the person is undetectable, the person won't be able to transmit HIV through sexual route of transmission. In terms of tolerability, there are many patients who actually discontinue ART because of the adverse events. 2 versus 10% of the patient discontinued ART at 48 weeks as per the single study, which are on efavirenz or TDF or dolutegravir based treatment. So in terms of tolerability, efavirenz dolutegravir based regimen are much more tolerable than efavirenz based regimen. You all know that efavirenz has this neuropsychotic side effects. So it may cause neuropsychosis in some patients, like side effects like giddiness or weird dreams, and all those side effects of neuropsychosis may happen because of efavirenz. Most of the times these are self-limiting, but the problem is that patients discontinue ART within the first months of time. So if you compare that with dolutegravir definitely has upper hand. In terms of genetic barrier resistance, as I said, this will be discussed in later part of the course. But what it means in simple language is how quickly a virus can develop resistance to a particular drug. That is called as barrier to resistance. So DTG has a high genetic barrier to resistance, which means that it is difficult for the virus to develop resistant strains against particular drug. So which means that patients who are on dolutegravir based regimen will continue to be on DTG based regimen without failing their treatment. So this is just a comparative depiction of different ART drugs in terms of their barriers to resistance and potency. So some of the drugs like Nevin and efavirenz, they are highly potent, but in terms of barrier to resist, they are very on the lower scale. But if you look at the DTG and darunavir, these are the drugs which are at right upper corner, which are very highly potent and highly and having huge barrier to resistance. The same graph you will see in the session of resistance, where we will talk about talk more about it. But here, just to make a point, DTG as a huge genetic barrier to resistance. Now, this is one actually point where there was a kind of backlash on DTG when it was everything was great about DTG until this happened in 2017-18, where there was a study from Botswana. It's a South African country next to South Africa, where 4 patients were seen out of 426 women. So babies born to these 4 patients or 4 women had neural tube defects. So which was higher as compared to the routine, incidence of neural tube defects. So there was the incidence of neural tube defect in the patients who conceived at the time of where when they were on dolutegravir based regimen. So it was 0.9%, which was as compared to 0.3% huge. 0.12%. So the if this actually raised an alarm whether this is the drug uh, which is causing actually the neural tube defects in these patients or in these babies. So it is being studied from then, and still there is the evidence is being generated. So to begin with, it was 0.9%, but as per the recent data which is available in 2019, the incidence of neural tube defect is 0.3%. But again, as and when the denominator increases, more and more women you study on, the incidence is going to be lesser and lesser with time. So, as you know, that when efavirenz was used in the beginning, this was the reason we were not using efavirenz in the trimester of pregnancy. But with increasing evidence, that went off, and now we are using even in the first trimester of pregnancy. So it is not contraindicated, definitely not contraindicated in pregnancy, because you know that neural tube actually closes in the first month itself, maybe at 28th day of gestation, and pregnancy is diagnosed usually in the 6th week or maybe after a month time usually. So by the time you diagnose the person on person's pregnancy, a woman's pregnancy, the neural is already closed. So those women who are already on DTG based regimen, while they are diagnosed pregnant, they are continued on DTG based treatment. But those women who are in pregnancy potential, they are given a choice because the benefits of DTG are so high that the risk of having this particular adverse event is again very low. So when it comes to ART initiation of the women in age group, when you start them on ART, all these things are discussed with them, that benefits and also their risk of neural tube defects and all that. But as per the WHO policy brief of 2019, they say that benefits of DTG for the women of childbearing age, they outweigh the risk which are associated with it. So that is why it's not a contraindication in women of childbearing age group. Of course, it's their right to know. That is why everything is explained to them, that this is the risk of neural tube defect or possible neural tube defect, and this is what they can out. But those pregnant, they continue to be on the dolutegravir based regimen. So she knowing everything, and don't just come and think, okay, this is risky and that is why we won't be using for all the women of childbearing age group. No, that is not the scenario here. So you should explain this properly to women of childbearing potential. These are the benefits of DTG. These are potential risks, but the benefits outweigh the risk, as it is apparent. And right now we are still again collecting the data for such women. And when time comes, the new data will be shared with one. But this is the case as of now. So, though for those who opt out of DTG based regimen, so for them, if they are not planning to have pregnancy, the other method of contraception can be advised, and also the those who are in, they to be supported for adherence. So NACO decided to introduce dolutegravir in phased manner. As I said, this is the first phase we are in. So, dolutegravir based regimen for PLHIV, it can be given for all PLH or CLHs or children living with HIV, also those who are more than 6 years of age or weighing more than 20 kgs of weight. So these will be preferred regimen in very near future. So those who are for new ART initiation, and as it will be introduced in the phased manner, and I will be issuing office memoranda time to time whenever the new combinations will be available. Right now, the availability is the individual DTG drug, dolutegravir drug, so which is being used for specific group of people. We'll see that. So this will be the upcoming guideline. TLD will be the combination, which will be able to use for all kinds of population. But as I said, when the combination is available, it will be known to you, it will be available to the artisan use. As it is in combination, we use for more than 10 years of age and 30 kgs of weight, not because of dolutegravir, but because of tenofovir in the combination. So if it is less than abacavir will be used, but DTG will be there. And if is having suppose renal toxicities, again, if creatinine clearance is less than 50, then abacavir will be used in such patients. And if the patient is rifampicin based regimen, now DTG may interact with rifampicin. That is why the dose of DTG will be doubled as long as the patient is on DTG based regimen. That means the HIV co-infected patients will have TLD tablet in the morning and additional DTG tablet in the evening. Again, all these are coming up, so this is not the current guideline. Only, yeah, but if you're using as a part of phase 1 transition plan, obviously if any of your patient who is on DTG based treatment and also is having TB treatment simultaneously, then obviously the same thing applies to that patient, that the DTG DTG will be used twice a day, and with in addition to the other the patient. So this is the checklist need to be followed. ART initiation, patient has to be registered. All the counseling is being done. Consent is taken. Prophylaxis is given. Consent form is signed by the patient, and adherence counseling has been done properly. And we are reporting adherence is through pill count, which we know that is not the right way, but we all should know how to calculate the adherence. There is a formula for calculation of adherence, says that all when adherence is calculated, it is for a particular duration. If you are calculating it for a month will have 30 days usually, and of those 30 days, if the 30 tablets were expected to be taken by the patient, that will go in the denominator. So of those doses which were expected to be taken, how many were taken actually by the patient, that becomes the numerator. And if you multiply that 100, you will the adherence percentage. And if you want to take a shortcut, there is an application of by NACO as ART adherence calculator that also can be used to calculate the adherence. Now, lately, this viral load concept or viral load was introduced to the program. I know time is up, but I'll quickly go to the remaining slides. Maybe it will take 15 minutes or so. The concept was in the session done by the UW faculty, but now it is 95, means the patients who are HIV, 95% of them should know their status, and those their status, 95% of them should be on treatment. And of those 95% on treatment, 95% of them should have viral load suppression. So viral load was not available to everyone, but these days viral load through one or the mechanism is available to each and every ART center. So initially we started with uh, targeted viral load testing, or there was some priority population for viral load test, but nowadays priority has been expanded. I'll come back to the priorities, but just before that, how viral load relationship is with the CD4 count. So usually it is an inverse relationship. When you start ART, viral load reduces and CD4 increases. We don't do baseline viral load, but we do viral once the patient is on ART. So after 6 months of ART, we do the first viral load. Then after 12 months, that is next 6 months, you do the second viral load. And if that is suppressed, we do annual viral load testing in those patients. So right now, there is a PPV mode viral load testing, which is available at all ART centers. And at some of the ART centers, you will have the viral load machine itself, so which is in public sector viral load lab. And there was a plan to use CBNAT machine also for viral load testing. These are the 7 categories of the people in which viral load is being done. Immunological failure cases, all these are priorities. But once you are done with all these priorities, then routine viral load is you can also do the routine viral load testing in all patients who are on ART for more than 6 months, and adherence if it is more than 95% for minimum 3 months time. And after doing the viral load, next viral load after 6 months of the first one, and if that is suppressed, then annual viral load testing should be done for all patients. So priorities are immunological failure cases and women, then key population clients, those who are on second line, children below 15 years of age, and those who are on ART for more than 3 years of age. And recent category which was added, all those patients who are on ZLN regimen, and obviously if adherence is good in last 3 months, their viral load is to be done as soon as possible, because these are the potential candidates for TLD based regimen, because slowly you will see less and less zidovudine also in the program. So that it is being recommended that by the time TLD regimen is made available, do viral load of all these patients who are on ZLN, which is quite a lot. And this is how viral load results are interpreted. I've done all these slides, that's why I'm skipping. But if viral load is more than 1,000, it is said to be unsuppressed viral load. That means that patient is to be done under step-up counseling, 3 consecutive sessions, in which again barriers are identified, adherence is reinforced, and again viral load is repeated after 3 months. And if repeat viral load is more than 1,000, then it is said to be having virological failure. Because if viral load is more than 2,000, it means only 2 things. 1,000, it means only 2 things. One is either the patient is not taking ART regularly, or the patient's ART itself is not working. If ART is not if patient is not taking ART regularly, then adherence need to be worked on. If ART is not working, then switch need to be made, which is only done after 3 months of step-up counseling and repeat viral loading, and then taking a decision. If viral load is less than 1,000, it is said to be suppressed. It is not ideal though. Ideal is D, it is target detected, but still we are happy that if viral load is less than 1,000. So this is what the algorithm looks like, which I already said just now. Skip these slides, and these are steps of step-up counseling, where you try to identify the barriers and then you try to deal those barriers to resistance. And if after the repeat viral load, if viral load is more than 1,000, then the patient is referred to SASEP through e-mechanism or virtual SASEP, or through physical SASEPs. SASEP means State AIDS Clinical Expert Panel, which decides whether the patient need to be second line or not. I think before slide was there, in the plan, DTG will be initiated in the first phase for these two categories of the patient, those who are already on raltegravir-based regimen and those who need to be switched to the third line or alternate second line, and where DTG will be a preferred drug instead of raltegravir. And this is how it is being used for all transition patients. Those first viral load need to be repeated, and as because of this COVID scenario, we are not able to do viral load testing for all patients. So last 6 months viral load is to be good enough. So based on that viral load, decision is to be taken. If viral load is suppressed, you will change this raltegravir to dolutegravir plus loperamide, and in third line again raltegravir will be changed to dolutegravir plus darunavir. Again, you need to follow the whole guidance. I'm just skipping through. Raltegravir, which was being used as alternate second line, was third line. So in place that dolutegravir will be used as alternate second line or third line drug. And this is how monitoring of the patient for those on DTGs. And some important points for the ART center, that counseling need to be done properly, viral load need to be repeated properly. People should know about all benefits of raltegravir-based treatment, and overall about ART to be able to explain to the clients that how beneficial ART is, and all those things need to be explained properly. So this is what I wanted to say regarding introduction to ART. As there are many things which can be spoken about, which I already skipped, like individual drugs and their pharmacology, side effects, and all those things are important. But principally, I think many of you are already working in ART sensor for some time now, and you all know that how these things work. As far as ART is concerned, the basic principles are really important to know, and those will have to be studied repeatedly. That is why all these courses are helpful, and trainings, NACO trainings will be important. So very soon, NACO has already actually started blended training, and that will be reached to everyone very soon. So repeated trainings will be helpful because all this ART thing is introduced and reintroduced repeatedly in different shapes and forms. And as I said, there will be further phases of dolutegravir into the program as well. And then more and more discussions on ART will happen. This was an introductory session. And like I said, there will be another session on related to ART, which will be having discussion on resistance to ART, second line and third line options also. So if there are any questions on ART and related topic, I'll be happy to answer. If not, then I think it is really important for you all to submit the quizzes on time, and please keep attending these sessions and going through all those quizzes and homework assignments. And if you have any follow-up questions after that, again, I'll be happy to answer those as well. Praveen, you can unmute us if there are any questions. If you want to speak up, you can obviously speak up.
They can unmute and respond.
There is a question. I'm just going through the chat box.
Thank you,
I think I have.
Thank you. Chat இருக்கு.
I'll pay thank you போடு.
எங்க மாமா?
Reproductive. See, folates or these supplements, one of the reasons for neural tube defect is again like iron deficiency or folates deficiency can also be one of the reasons for neural tube defects. So obviously for that it will help. Directly for DTG, there are no studies to adding folate will help in reducing risk of neural tube defects because of DTG. So that you cannot skip. Yes, obviously, patients who are pregnant or in childbearing age group, should be taking folates to reduce that risk of neural tube defects because of folate deficiency, but not it won't be helping because of dolutegravir. There's no enough evidence to say that. Any benefit of or disadvantage of same day ART initiation? I won't say that it is a disadvantage. In fact, I would say it is to start ART on the same day of diagnosis or registration into the ART center. But obviously, while doing so, you want to make sure that patient is adequately prepared for ART. So, in just to start ART on the same day, you should not be ignoring the importance of preparedness and ruling out. Adequately ruling out opportunistic infection. So as a clinician, I think you will be the best judge of when to start ART, but same day ART initiation is an increasingly popular concept, which is being advocated everywhere. I apologize for disturbing audio at my end. As I said, I had this limitation of using an internet which is not good enough for sessions.
Good
So
idea.
yeah, no
அப்ப
further.
எனக்கு பழைய டெஸ்ட் எல்லாம் எடுத்து கொடுத்துறேன்
Thank you very much. Future the course. Thank you.
Thank you, sir. Thank you to all the participants. We'll share the recording soon.